Welcome everybody to LDI's seminar, an action plan for reducing opioid overdose deaths. I am Rachel Werner. I am the executive director of LDI, and I'm thrilled to welcome you all here today. Before we get started, I want to thank our co-sponsor for this seminar, which is the Center for Health Economics of Treatment Interventions for Substance Use Disorder, Hepatitis C, and HIV, more commonly known as CHERISH. We are joined today by Ricky Blumenthal, who is a professor in the Department of Populations and Public Health Sciences, the Vice Chair for Diversity, Equity, and Inclusion, and Associate Dean for Social Justice in the Keck School of Medicine at the University of Southern California. His research has tested interventions for people who inject drugs, documented how community conditions contribute to health disparities, and examined health policy implementation. We are also joined by Keith Humphreys, who is the Esther Ting Memorial Professor in the Department of Psychiatry and Behavioral Sciences and founder and co-director of the Network on Addiction Policy at Stanford University. He also leads the Stanford Lancet Commission on the North American Opioid Crisis and is a frequent advisor on opioid policy. And our third panelist is Regina LaBelle, who is director of the Addiction and Public Policy Initiative at the O'Neill Institute for the National and Global Health Law of Georgetown Law, and is the former acting director of the Federal Office on National Drug Control Policy. Working at the intersection of law and policy, her work focuses on identifying policies to reduce overdoses and to promote access to addiction treatment, harm reduction, and recovery support services. Today's panel is being moderated by Shoshana Aronowitz, who is a family nurse practitioner, community engaged health services researcher, and assistant professor in the Department of Family and Community Health here at Penn Nursing. Her research examines innovative delivery models to promote equitable access to substance use treatment and harm reduction services, as well as racial disparities in pain management in the context of the opioid overdose crisis. Thank you all for joining us today. I'm looking forward to this exciting conversation. And with that, Shoshi, I will turn it over to you.
Thanks so much, Rachel. Hi, everyone. Thank you so much for joining us today. It's really an honor to moderate this panel. So I know everyone in the audience is really eager to hear from our panelists, as am I. So let's jump right in. The CDC has reported that more than 100,000 people in the United States died of a drug overdose in the 12-month period ending in April 2021, and most overdoses involved opioids. This is a nearly 30% increase in overdoses compared to the year before. Today, we're going to talk about what's driving this increase and what we can do about it. Let's untangle the complexities of legal and illicit drug markets, social inequality, treatment options and barriers, and disparities in the communities hit hard by both the COVID-19 pandemic and the ongoing opioid overdose crisis. To get us started, I'd like to ask all of you, what main factors contributed to this increase in overdose deaths? And at this point in the pandemic, how influential do you think these factors continue to be? Ricky, if you don't mind, let's start with you.
Oh, sorry about that. Sure. So obviously it's a complex health problem, and I think it's driven by a wide variety of factors. What I'd like to probably start out with, though, is just highlighting that we haven't had the kind of local, state, and national response to this crisis that we need to. We actually have many effective solutions, most of which involve engagement with people with lived experience and peers in the distribution of things like naloxone, safe injection supplies, drug consumption sites. Like, there's a lot of things that we could be doing if we were willing to take them to scale, and we've just never done that. So I want to highlight that. So we haven't had the kind of national response that we need to deal with this issue. I think the other thing is that we have to acknowledge at this point, we really have no control over illicit drug markets. And now that fentanyl has gone national, and we're seeing that now in the West Coast, in Los Angeles and San Francisco, we're going to have to sort of step up our game in terms of contemplating what are things that we can do right now that would facilitate access to medications for opiate use disorder, and then delivery systems that actually facilitate getting them to the people who need it most as rapidly as possible. Perhaps the only positive benefit of the COVID pandemic is that we have seen a loosening of regulations around the availability and prescribing of medications for opiate use disorder. And we need a lot more of that if we hope to preserve life in these conditions. And, you know, we have to do that with some urgency because the fentanyl isn't going away. It's probably, if it's going to be replaced by anything in the future, it'll be even more powerful synthetic opiates. And preserving human life really will require some radical rethinking and really leaning in to making these treatments more widely available to people.
Thank you so much, Ricky. Keith, I saw that you unmuted. Do you want to jump in?
Oh, yeah. So I mean, we have a three-wave epidemic is how we got here. So I agree with what Ricky said. We don't have control of illicit markets. We also lost control of the licit market from about 1999 to 2010. Opioid prescribing went up 400% per capita in the United States and in Canada as well. That created opportunities for heroin to either strengthen in markets where it had been and also to grow in new places where it really hadn't been. There hadn't been robust heroin markets in places like Youngstown, Ohio, and Parkersburg, West Virginia, and places like that, but they started to provide to people who got addicted to pills. And then we have fentanyl coming in about 4 or 5 years after that in everything, which has turned what was already a disaster into a complete catastrophe. And all three waves still continue. There are still people dying of heroin. There's still people dying of OxyContin, and there's still people dying of fentanyl. So we haven't really resolved any of those problems to this point. And resolving them is going to require us to do two things at once. One is to work in the acute end. So that's things like, like naloxone distribution is the number one thing that the Stanford Lancet model says will save lives, is dramatic expansion of naloxone. And that's great, much as monoclonal antibodies are great for people who are intubated with serious cases of COVID. But you never solve epidemics by just focusing on taking care of people at the extreme end. We have to go upstream. And that means doing things like, in the commission's judgment, investing in kids, especially kids in low-income, addiction-ogenic environments. It means making sure we use opioids well for those who need them, but do not prescribe them to those who do not. And also that we make sure we separate our institutions, our regulators, and our educational institutions from corporate interests that profit from the spread of addiction.
Thanks, Shauna. So I think, when we look at this in waves, as Keith said, but they've built on one another, right? And when we met the 100,000 mark in overdose deaths in April, it was announced, it was April 20 to April 2021. There was a lot of shock, but anyone who had been paying attention to this, there were a lot of modeling that was being done. We could see this building. And, I served in the Obama administration for 7.5 years, served in the Biden administration for 1 year. And there have been many things policies that have put into place, but some of the basic conditions remain, which is we have a lack of evidence-based treatment availability. We continue to have huge stigma associated with both people who attached to people who may use drugs, and also a stigma about even seeking treatment. So there's a lot that we need to do as a society. There are a lot of policies that we can put into place, but it really was only in 2016 when there started to be an increased amount of funding. That's on the grant side. The Affordable Care Act certainly was a game changer in terms of access to treatment, but we didn't get here overnight. It's not going to be solved overnight. And there's many things that we need to continue to do to put into place the solutions that are going to drive down overdose deaths, but more importantly, get people access to care who need it, who may not ever overdose.
Thank you all so much. I just noticed a question in the chat box, which if anyone has any thoughts, they want to jump in now, but also just to keep in mind as we go forward. Someone wanted us to talk a little bit about the uptick in stimulant overdose deaths as well, because of course we often focus on opioids, but these are not the only substances causing overdoses. So if anyone feels like they want to jump in now on that, feel free, but also as we move forward, if you want to speak on that at any point, please do.
Well, I just say a little about that. That we've had a resurgence of deaths, particularly where I am out west, and Ricky and I are both out west, from methamphetamine, and it's a mixture of things going on. So some of it is fentanyl penetration into the methamphetamine supply, and to some extent into the cocaine supply. Although at this moment, that's still a minority of the supply. And others part is you can certainly die. It's easy to kill yourself just from using methamphetamine. You can give yourself a stroke, you can give yourself a heart attack. And we see those things happening as well. And the meth is like fentanyl in that it is a very potent synthetic drug. And this is probably going to be more the future instead of agriculturally derived drugs. A lot of our illicit markets will run on synthetic drugs, which are very hard to control from a supply viewpoint.
Yeah, and the only thing I would add is I think we're also, so we've been in the field in Los Angeles collecting data since May, and not in all the neighborhoods we need to be into, but at least 2 of them. And what we're seeing is there, unlike what we had previously seen, there is just a lot of legitimate co-use of both drugs. So most of the people who use opiates now also use meth. And there's published studies and anecdotal reports about some of the explanation from this. Some of it is miseducation. So some folks have reported that they use meth to sort of prevent fentanyl overdoses, which is not sort of how either meth or fentanyl works in terms of overdose deaths. And then we've also had, and this, sort of as a backdrop to a lot of what's happened throughout the opiate overdose death crisis, there's the material conditions of people who use substances have diminished dramatically in the last 20 years. And it feels like it's even accelerating in places like Los Angeles. So when people find themselves unhoused, they will sometimes turn to meth use as a strategy to stay awake during the night, as a way of preventing robbery, assault, and other bad things happening.
There's a couple things too. So I live on the East Coast now, but I lived in Seattle for a long time. And in Washington State, we had a huge meth problem. But at the time, it was mostly mom and pop meth labs. And now we're seeing a resurgence of liquid meth in particular coming into the United States. And when I talk to people in New England, New Hampshire is seeing meth increasingly now. Now, meth in the Northeast was really not known. But if you look at drug trafficking networks around the country, there is an increase, again, because of this synthetic. It's the new wave of drug trafficking is really a synthetic base. It's not going to be a plant-based in 10 years, a plant-based economy for drug traffickers. It really is synthetics.
Thank you all for that. Echoing what Ricky said, certainly anecdotally in my practice and outreach work, that's something I hear a lot, people saying that using meth as a tool to stay awake, especially at night when they feel unsafe or they feel like things will be stolen from them. So thank you all. I'm going to move on to some questions that I have specifically for each of you, but anyone also can jump in afterwards. So Keith, you've modeled the effectiveness of a variety of policies to address the opioid crisis in the US, including those that affect drug supply, as well as those that affect drug demand. And you've recently updated that model to include pandemic-related changes. Can you give us some detail on what the model shows in terms of saving lives in the short and longer term?
Happy to. Let me credit Isabel Rao, who's the first author of the Lancet model, and Margaret Brandow, my colleague, also worked on the model. So there's, I have to say, some pretty sad news in that we project over 1 million deaths this decade if we don't do anything. That's the base case, as they refer to it in epidemiology. Some other models are, I wouldn't say more optimistic, but they're less pessimistic, but none of them that I've seen from any group around the country projects less than an extraordinary amount of suffering in the future for us. We can, though, reduce it. And the number one thing that came out in Isabel's model by far, as I mentioned, is naloxone in terms of overdose deaths. That we've done a lot to expand naloxone, and that's great, but we need to do a lot more. And if we could, boost it, say, by another third of availability, we would reduce hundreds of thousands of deaths over this decade. The second thing, which both Ricky and Regina mentioned, is access to evidence-based care for addiction. We are very fortunate. We don't have anything for meth, but we do have really good FDA-approved medications for opioid use disorder. And those need to be made more available. And there's lots of mechanisms to do that. For example, states like Tennessee that haven't expanded Medicaid and have an opioid epidemic should be immediately expanding Medicaid. Prisons, correctional facilities should all allow anyone who needs these medications to get them. There are lots of ways we could do this. And then psychosocial treatment, syringe exchange, both come out in the model as being life-saving. I mean, nowhere near to the level that you see with the naloxone and with treatment, but those are certainly beneficial. But I'll just restate the other point that those are all downstream interventions. That's for people who are already addicted, and you cannot solve an epidemic. To get rid of COVID, we need masks, we need vaccines, we need social distancing. We can't get rid of it with monoclonal antibodies. So we do have to remember upstream interventions, and I mentioned things like the commission highlights just investments in kids. I'm not talking about just say no programs. I'm talking about things like nurse family partnership, like Head Start, like pre-K interventions that set kids off, particularly kids in low-income neighborhoods and places that have already gone through a generation of addiction, set them off on a good course in life. That is very hard to persuade politicians and the public to make 20-year investments, but we really need to think that way. And then we also need to tighten up the regulatory system. There is no reason why 10 years from now we couldn't have another epidemic like this started in the healthcare system with a different drug, like stimulant medications or benzodiazepines, or we've approved ketamine now is out there. We may soon approve MDMA is out there. And the holes that companies like Purdue Pharma walked through largely remain. So the other preventive thing we need to do is let's not go through this horrible thing again with another drug, but let's tighten up how we approve drugs, the political influence of the industry, their ability to advertise to beyond any sane amount, all needs to be fixed on the preventive side. And it's hard to think long-term when we've got a crisis on our hands, but we have to do both things. We have to manage those people who have the problem, but we have to stop the future generations from going through this same thing.
Thank you, Keith. Regina, I have a question for you. Let's talk about the government's policy response to the overdose crisis during COVID-19. Can you give us a sense of the policy changes during the pandemic on both a state and federal level, and speak to how much of an impact these changes made in light of the alarming loss of life that we've been seeing from overdoses during the pandemic?
Yeah, thanks, Shoshana. So overdose deaths were going up prior to the COVID-19 pandemic, but this was actually during the Trump administration. They responded quickly in a couple ways. One was that they allowed for more telehealth, which allowed, actually, when I talked to treatment providers, they were really pleased with the telehealth provisions for addiction treatment because it allowed them to retain their patients in treatment. So I'll get to the research on it in a second. And then secondly, methadone, take-home methadone rules, regulations were modified during the COVID-19 pandemic. Now, the majority of states followed federal regulations. I mean, methadone regs are very extensive, very complicated. And actually, as we're speaking today, the National Academy on Science, Engineering, and Medicine is having a great conference, a 2-day workshop to advise the federal government on how they could change methadone regulations. So the COVID-19 pandemic, those regulatory revisions have allowed for a natural experiment. There will be more research about whether or not how the regulatory changes affected retention in treatment. But we do know a few things from the research that's been done. One is some of the survey research has said that people who were allowed to do more, have more flexibility, have longer take-home methadone, it made them, I mean, this is the exact quote from someone in the survey, it made them feel normal. It made them feel better about their treatment. So again, we'll look at the research about whether or not it enabled them to stay in treatment, but that's a good thing. And then secondly, we did not see an uptick in diversion from methadone from these regulatory changes. And that's also a positive thing. If you look at this through a legal lens, obviously, the Controlled Substances Act controls methadone dispensing, and there's a concern about diversion of methadone, and we didn't see that. So, number one, the sky didn't fall. Number two, we may have had better outcomes for patients. That will remain to be seen, but I think this time period has allowed us to look at it more closely and to actually say maybe we don't need these really stringent regulatory regulations for methadone. So we'll look at that in a little bit.
Thank you. I have one slightly different follow-up question. I saw you nodding your head when Keith was talking about access to MOUD medications for opioid use disorder in carceral settings. So I'd love if you could speak to policy specifically addressing the issues of treatment access in correctional settings, and those targeting folks who are previously incarcerated and people re-entering after incarceration.
Sure, thanks. So we know that you've got up to 40% greater chance of overdosing if you are not treated with a medication during while you're incarcerated. I mean, first of all, it's against the law to have someone who is on methadone or buprenorphine when they enter corrections, to force them to get off, to force them to withdraw. We know from federal court cases that's a violation of the Americans with Disabilities Act, that's a violation of the 8th Amendment. So it's illegal and you should continue people. Secondly, it saves lives. Now, the big issue, and we worked with, at Georgetown, we worked with the Sheriff's Association and the Bureau of Prisons on this issue. And there is a great interest in expanding access to treatment and corrections, to evidence-based treatment and corrections. And so a lot of groups like the National Sheriff's Association and others are calling for the Medicaid exception, which would to be eliminated. So the Medicaid Reentry Act would allow individuals who are incarcerated to get Medicaid access 30 days prior to treatment. And one last data point, we know from Rhode Island's experience, they decreased overdose deaths in the correctional population, the reentry population, by 6%, by 60%, and 6% overall in the state of Rhode Island by implementing treatment in corrections with Medicaid-based treatment.
Thank you so much. I'm going to give other panelists, if anyone wants to add anything to that, give them a second.
Yeah, I agree with everything Regina said. I've been to that prison in Rhode Island. It's really a terrific model of continuity of care. So you have the same provider when people are incarcerated, and then when they go out in the community, it's the people they know and they already know where to go, because we lose a lot of people in that 2 weeks after prison. The death rate is just appalling. It's like being in combat. It's so awful. And it's not enough to say, well, there's a clinic out there, good luck finding it. But instead, you have somebody meet you right there at the gate, someone you know where to go. And it's remarkable how life-saving it is. More generally, some of the other points the commission makes about corrections is we also just need to pull back the basic concept that we should punish people, put people in a cage at all because they are addicted to an opioid. I'm not a lawyer. I think that's, but I'm going to say, just as a lay person, that seems to me cruel and unusual punishment. They go through withdrawal, that is horrible. They're at high risk for addiction, that is horrible. Those are added punishments on top of a punishment that isn't deserved in the first place. And instead, the correctional system has to remember it has a rehabilitation mission. Yes, we deter. Yes, we protect the public, but it's also supposed to rehabilitate. You have a duty of care for every single person who's incarcerated, and that includes people who are addicted.
Thank you. Yeah, and to add to that, the trauma that's often, or almost always, I'm sure, associated with incarceration. There had been a question in the chat about the role of trauma and substance use disorders. So certainly the experiences that people have in prison could accelerate that. Ricky,
Let me just add on to that. I mean, I do, it's worth noting that incarcerating people for substance use disorder is a highly effective negative intervention. The people that I see in my studies who are chronic heroin and methamphetamine users, many of them, never completed high school because they were in jail for substance use. as an adolescent. And then as people go through the life course and begin to take on other responsibilities, periods of incarceration disrupt their capacity to build families and raise children, to get employment. And then of course the stigma associated with being previously incarcerated creates a long-term drag on people's life opportunities over time. So, I was happy to hear about the focus on upstream interventions in the Lancet, because it speaks to how stop putting people in jail for substance use is also an upstream intervention. So decriminalization of individual use absolutely has to be on the table as a way of stopping the negative effects of the war on drugs on both individuals, families, and communities.
Thank you, Ricky. I actually have some more questions for you. So the longstanding war on drugs and the pandemic have both had devastating and disproportionate impacts on communities of color. As we craft treatment and policy strategies for the future, what do we need to keep in mind in terms of social justice, structural racism and racial disparities, and equity? And what role do community partnerships play, and what do policymakers need to build that perhaps they hadn't in the past in order to be successful?
Yeah, so I mean, I think engagement with the community is key, but the community of people who use drugs and their near peers. I mean, one of the things that's been a persistent problem, and one of the reasons why we don't have more comprehensive availability of both treatment and harm reduction services, is that some members of communities don't want those things around them. And so that ends up meaning that, like in my last study, we looked at in Los Angeles and San Francisco who had access to naloxone, and naloxone access was lowest for African American and Latino people who inject drugs in those two cities. And that was data from 3 years ago. But that some of that has to do with this sort of NIMBY stuff. The other piece is that I think policymakers or politicians have to be more intentional about directing where these services go. One of the things that's the case is that the kinds of treatment that are available to people, or the kinds of harm reduction services that are available to people, are better understood by politics rather than need. So we really do need, and the system that comes to my mind is the sort of system that we put in place to deal with the HIV epidemic, where you had the CDC making money available and then supporting community planning commissions to provide evidence-based services to places. And it was predicated on the number of cases. And we don't really have that kind of feedback system happening with overdose deaths yet. So there can be lots of deaths, and then someone decides to not do anything because they don't like the preventive alternatives. And I think it's a problem with our politics. And it has a devastating consequence on people of color and other minoritized populations, because they end up not getting the service they need, or they get the negative intervention in spades, right? So they get mass incarceration. They end up in these correctional settings, which are, as Regina pointed out, most likely in violation of the law by not making treatments available to them. And that's a choice. Right, those are not people operating in anyone's best interest. They're very narrow-minded, and they have devastating consequences. So, I do think at the end of the day, we probably need a better politics of inclusion in this country, and recognizing that we're connected to each other, and that when people are suffering anywhere, we're all suffering a little bit, and we don't have to. We really do have solutions. We just have to have the political will to make them available to people.
Thank you. That started to touch on a question I was going to ask later, but I'll ask it now. I'd love if you could speak to the importance of including the voices and perspectives of people who use drugs in research and policy development.
Sure. I mean, my own view, and I was sort of there in the beginning, at least, of the syringe exchange movement in the United States, is that, these ideas didn't come from physicians or sociologists or economists. They came from the people with lived experience. And what we discovered early on is that people were using syringes, multiple people were using syringes because there was a syringe scarcity. And then once you dealt with that syringe scarcity, the problem was diminished tremendously in terms of HIV transmission through sharing syringes. The same thing happened with naloxone. You know, Dan Biggs, the sort of godfather of providing naloxone to people who use drugs, started doing that in the mid-90s. And the people who are doing these reversals, and the reason why naloxone is so effective is because people with lived experience, when you give them the tools to preserve life, are willing and able to use them. You know, we have to, you know, we have to use all of our assets. And the truth of the matter is, with hidden populations, like folks who use illicit substances, the people who use them are an important asset, and they need to be central to discussions about how to respond. And so, just on that point, I mean, one area that sort of sticks in my craw a bit is, you know, all of the limitations on the medications for opiate use disorder that there are, both the regulations, but also, you know, there's weird dosing regulations sometimes, and there's not much attention to how do people want to use the medication. You know, we live in a country where there's 24 different kinds of aspirin. You know, why can't we have some variety in the ways that medications are made available to people who need them, and like really engage with customers around, you know, all right, maybe you want a microdose of Suboxone, or, you know, maybe you want a larger dose of methadone, you know, whatever the case is, but having conversations where you recognize that there's a person across from you who has their own human dignity and autonomy, and collaborating with them around helping them is probably the most effective way to deal with a lot of these issues.
I want to add,
Can I just add one thing? Oh, I'm sorry, Regina, go ahead.
no, quick. So I wanted to say, Ricky, what you said, you know, for the first point about the using meth at night, heroin in the morning. I mean, really the only reason we'd know that is if we talk to people who use drugs. And I heard that in Seattle, and it was really revelatory to me, because I wouldn't get that otherwise. But the second piece is, I've been thinking about this a lot in terms of the methadone workshop that's going on right now. Now, as a lawyer, you know, we wrote these rules as lawyers write them, which is very black and white, you know, very like, this is the rule. But it doesn't take into account the clinician or the human side. And that's, I guess, what we're asking now of the system that was developed by lawyers, which is very concrete and doesn't allow for the types of things that take into account the human needs that someone might have.
Just want to add one thing too, is to remember that there's also generic investments in health that would benefit disproportionately people of color and people who have addiction problems. And I will give a signal example of that, the Affordable Care Act. Regina and I both worked for President Obama when that passed. It was not billed as an addiction treatment program. It was not billed as a racial disparity remedy program, but it had massive benefits on both those scores. I mean, between the regulatory changes and the new insurance, more than 50 million people got improvements in their coverage for addiction and mental health, gaps between access to care for African Americans and whites dropped in a lot of the country. We need to continue that work. I mean, one thing in the addiction field, we do tend to get narrowly focused on what are the addiction-focused services, but just to remember, if it's truly health, we should be saying everybody should have access to healthcare, all sorts, because a lot of the problems people have are not going to be addiction. It might be mental health, it might be housing, it might be infectious disease, or it might be, you know, a flu, you know, all the problems everyone else gets, but they can't get it if they don't have insurance. So I think we need to keep pushing on the idea that every state needs to expand Medicaid. All states need to adequately get their healthcare marketplaces working. We need to not undermine companies that provide that insurance. We need to support those companies so that we can get to a goal where every single person in this country has health insurance. Some people who are a lot smarter than me who study this just think that the only reason we don't have it, and every other country does, is because of racism. Our unwillingness, or the unwillingness from part of the population to give anything to African Americans, even though it would benefit them too. They will cut off their nose to spite their face. And a better society, a less racist society, would overcome that and say every single person has a right to see a doctor if they need to.
Thank you all. So now I have a bunch of questions that are for everybody. So anyone should feel free to answer. And this was one person asked about this in the chat, but taking stock of treatment and policy strategies we've seen during the pandemic, what should we be continuing into the post-pandemic world? And how would you advise policymakers on this? Someone specifically asked about telehealth, which Regina, you talked about a little bit, and mobile methadone, mobile buprenorphine programs, things like that.
Well, I think both can, both are great, and we should do more of them. So I've been doing the kind of studies I do for about 30 years now, or actually a little over 30 years. And at no point in those 30 years has treatments been more readily available and less expensive than illicit drugs. So I think there is an argument to be made that we could greatly expand the availability of methadone and Suboxone in a way that, probably isn't ever going to be less expensive and more readily available than illicit drugs, but can begin to close that gap. And I think that would be entirely beneficial, particularly in the context of the fentanyl taking over the market. I mean, we have to realize that every time someone isn't using fentanyl, if they're using Suboxone, methadone, whatever the source, whether it's through a regular prescription or diversion, that's one time they're not using fentanyl that may kill them. So I think we need more of that, and we need funding to support the implementation of that in all the places that it's needed. We probably would benefit from some federal guidance on this. There's some states I think West Virginia, in fact, just outlawed methadone treatment. I think that's what I read in their latest legislation. And, we've got to stop that, right? Because those kinds of approaches literally result in increased loss of life.
If Regina, if you want to jump in, or Keith, feel free.
And so on the telehealth piece, there's some legislative steps that need to be taken in order to allow more access to it. There are areas in this country that obviously don't have good broadband access, so that limits it. Also, the types of phones that people have may limit it. So there's a number of pieces of legislation floating around on the Hill that would do that, that would revise it and make it more accessible. But I think that, I don't know if you've noticed, but Congress is a little tough right now. And I mean, they still don't have an FY22 budget. And the FY22 budget that the president proposed has $40 billion for all aspects of drug control, including more than half of that would go towards addressing substance use disorder addiction. So I think part of this is that, it's kind of continuing to keep the policymakers' attention focused on this issue going forward, that it isn't going to go away, that it is a chronic condition that they need to pay attention to and pass the types of laws. I mean, they're not passing a lot of legislation. And so in lieu of that, the executive branch can take administrative steps to the extent possible, get regulations. That mobile methadone ban was a decade in the making. And it was only through really consistent pushing them that it finally got out. And it's still not perfect, but it's better than it was.
I just add one other thing is that we do need to continue doing the mixture of clinical experience, patient experience, and science, figure out how to respond to fentanyl very practically. So there's a lot of arguments among my physician colleagues about do you need to be on methadone if you're addicted to fentanyl because it's a full agonist to get to get stopped? What dose of naloxone is appropriate? Do they need to be stronger? Something absolutely yes. Some say no. Should we be doing slow, sort of a mini dosing of Suboxone to people coming to the emergency room to try to relieve them of the acute risk of fentanyl or not? And how do you do that? We need to figure all those things out really, really fast. The fentanyl, my colleague Phil Coffin calls fentanyl it's like the ultimate antibiotic resistant infection. It's overcoming a lot of the things that we used to do that worked, and we still have to very quickly pull together the best frontline knowledge and get it out there so that everyone knows how it is we can save lives, which may be different than what we've ever done before.
Thank you. Piggybacking off that, there's been a few questions in the Q&A about harm reduction initiatives, like the impact of safe consumption sites and safer supply. And I would love if you all could comment on that and talk just generally about kinds of innovation that you'd like to see in addressing the overdose crisis that haven't had much traction here in the US or don't currently exist.
Yeah, I mean, there is a pretty substantial literature on heroin-assisted treatment, for instance, and it's, it's very effective. The reports from the studies in Europe indicate people's use declined over time, their education and employment gains improved. So it's certainly something to consider. I think the important thing to keep in mind is that there's never going to be one thing that works for all of these problems, as has been indicated by all of the conversation from the other panelists. And so we can approach some of these problems thinking like, look, there are some discrete groups where, hey, if you made safe supply available to them, that's really going to work for them. And we should be open to exploring that. Similarly, the drug consumption sites, and now we have one, that are two in New York that are operating to go along with the hundreds, perhaps tens of hundreds, or multiple hundreds of them that exist in the world, and in particular Canada. And there's really no downside. Like when people are using drugs in those settings, they're not dying from overdoses, they're not sharing syringes, they're using in a clean place, they're unrushed, so there's less likely to be injury associated with their use, and they're building community. And getting access to other services, including treatment, and medical services. So, I think you can't solve a problem that you're not trying to solve. And we do have the tools. So I just want to reemphasize that, we need the investment in making them available to people. And we need to, stop having bad faith arguments about what are the downsides to these interventions, because we've looked at it and there really aren't any that are significant or that come close to outweighing the harms of doing nothing, right? And that's how we got to this place, right? You have 100,000 deaths because we're not doing enough, and there are many places in the United States that aren't doing anything, and we really should be pushing for a vision of our response to this challenge that sees that people are implementing something, right? And then implementing the full menu of things that are going to help preserve life in the midst of this crisis.
I think on the issue of supply, it's really a question of finding the right balance. It's just hard to do in a very polarized discussion in a polarized world. The Opioid Commission listed, I can't remember how many there were, probably at least 20 different ways of giving opioid agonist therapy in developed countries. From injecting methadone to hydromorphone to slow release oral morphine, and we have two. And if you compare that to anything else, asthma, depression, cancer, we have a gazillion things because we expect people will have preferences and they'll be different and they'll be diverse. So we suggest accelerating all that. Particularly we have drugs. Hydromorphone's already scheduled. Slow release oral morphine is already scheduled in the United States. And we have lots of good safety and efficacy data from Europe, from Australia, from Canada on those medications. Those should be moved out very quickly, and we should be looking at all of them. It is at the same time, Commission notes at least some people are enthusiastic of not so much clinic-based, but just distributing large amounts of opioids, methamphetamine, benzodiazepines. And we caution there, just remember that hundreds of thousands of people died from legally manufactured, clearly labeled opioids of consistent quality in the first phase of this epidemic. So it is not the case that the less control you have, the more lives you save. At some point, a lack of control ends up killing people. So that we need to find a sweet spot where what we do, we have a good regulatory framework that genuinely helps people and does not initiate new people into addiction or cause overdoses.
The thing I'd add is that, when we started in the Biden administration and even before, we were working on during the transition, that, I'll tell you, I knew I wasn't going to be in the administration for a long time because I needed to get back to Georgetown. But the one thing I wanted to do, and worked with, numerous people, is to use that research about what works and what is characterized as harm reduction to actually articulate that in the Biden administration's drug policy priorities, and to start kind of laying the groundwork. I mean, overnight success in this area looks like it happened overnight, but it's not. This was a very long time in the making. And, we started in the Obama administration getting more acceptance for syringe services programs. There are over 50 in the Commonwealth of Kentucky now. Again, that groundwork has to be laid. It takes a long time, but and people don't have a lot of time, and I understand that. But unfortunately, that's the way the policy is working. That we have to kind of, you build that groundwork, you get the research in front of the policymakers, and you tell them how it's going to work.
Thank you. Piggybacking off of that, a question that I know has come up a lot recently, people have been talking about the very recent backlash surrounding safer smoking supplies and how that kind of quickly took off. And, I appreciate, Regina, what you were saying about how long some of these changes can take. And it kind of felt like in a blink of an eye, all of a sudden we were discussing things like access to syringes again that took some people by surprise. I'm wondering if anyone wants to comment on that.
I mean, it's just an unfortunate reality of our politics. I wish we had a caring reactionary party. So when there were problems happening, like, hey, let's rush and try and solve it, rather than play the easy political game of shouting slogans without providing solutions. I think the contemplated legislation, if it even comes to fruition, is as ridiculous as the ban that existed on syringe service programs at the federal level, funding for syringes. It only helped facilitate the transmission of HIV and then hepatitis C in this country. We probably need a politics of accountability, where if you repeatedly come up with bad ideas that harm people and don't solve problems, there's some penalty for that. But unfortunately, it doesn't seem like we live in that world. But yeah, I mean, you have to want to help people. When I began doing this work years ago, I didn't see drug addicts or poor people. I saw older versions of Ricky. Right? Or younger versions of Ricky, or Rickies with different experiences. But I saw myself in those people, and I recognized their human dignity, and thought that, if there's something I can do to help, I should. And there really is a lot that we can do to help. And ignoring these problems doesn't solve them. Politicizing them, even when it's easy, doesn't solve them. And we really need to focus on solutions.
I think drug policy is always worse when it's on the front page. I mean, you can get the most done when it's not an issue that will draw a crowd of screaming people and a lot of demagoguery, because it's so easy to demagogue about this issue. And so that whole tempest in a teapot, it just brought me back to like the 1980s with despair and sadness that this had happened again. And I think we just have to do the best we can, those of us who care about this issue, to not get sucked into culture war stuff as much as we can, focus on the big things, focus on what saves lives, and just push it in a calm and rational way. And that is very hard to do in a Twitterized, Instagrammed world where you're driven out of your mind, by all the rage out there. But we have to be the grown-ups, focus on the big things and drive those forward as best we can. And it can be extremely frustrating. I can't say, though, on the upside, this epidemic has been terrible. Utterly terrible, obviously. If there's any silver lining in this atrocious cloud, It's that every single member of Congress has heard about this from their constituents. So regardless of their politics, they've had, I promise you, families crying in their offices over their losses. So there is a basis, if we can stop the culture war stuff and just get down to the common humanity of, do you want people that you care about to die from an addiction or not? We can find a lot of agreement. I know that sounds kind of kumbaya, but I worked on the Support Act 2018. I saw a lot of that. There was a lot of cross-party work. I heard a lot of moving things from people in both parties about what they're seeing in their districts, what people are saying to them. I think that reservoir is still there, not on the front page, but in the back room. And so that's what I count on as I try to work in this policy area.
Thank you. I have a few great questions that were in the Q&A that I will ask for anyone who wants to answer. So someone said overdose deaths are of course important and I don't want to diminish them, but there's been little talk of non-fatal overdoses. ED visit numbers for overdoses are 5 times those of deaths and half of overdoses are self-managed. So we'll have 1 million overdoses each year. Non-fatal overdoses strongly predict overdose death. How can we use this information to agitate for change?
Yeah, that's a really good point, because we are focusing, I mean, we measure how well we do based on the rate of overdose deaths when that's the tip of the iceberg. And it's a good point. We do need to keep track of, I mean, we don't have great data on overdoses that don't end in death. But it does go back to what Keith said about, naloxone distribution. And I think I don't really see the reason why naloxone has to be prescribed. I don't understand why it can't be over the counter, why it shouldn't be made more available to people at great risk, particularly, so anyway, I think that it's a very good point. We don't have great data, but more naloxone distribution is needed.
One idea we float in the Stanford Lancet Commission is the United States just buying the patent, for example, on like I forget how you say it, SVO or something, that automatic thing, but just buy it, make it a public good and give it away. We could do that. Probably wouldn't cost that much money, maybe $3 billion, which is pocket change given how many lives it would save. I also want to say, since I have the floor for a second, I agree about non-fatal overdoses. And also, let's not forget about addiction. I sometimes worry that we forget, like, being addicted to heroin is a very, very tough life. And that we, of course, we want to stop every single fatal overdose, but millions of people being in this health state is really a public health disaster, really tough on them, tough on their families, tough in their communities. And that's why we have to, again, kind of move upstream, which is, you need to treat people even if they never have an overdose, and you need to invest in prevention so we can divert as many people as possible from getting addicted in the first place.
Thank you. Another question from the chat. What interventions, policy or clinical, are available to address stigma, which is pervasive throughout the system?
Well, I mean, there is, I think people are trying. There's some campaigns in different states. I think South Dakota, I feel like, had an interesting one around methamphetamine, which was trying to destigmatize. There's a work by people like Robert Ashford and others around the language we use. So you'll notice today, we're talking about substance use disorder, not abuse. We're talking about, recovery, not necessarily abstinence. So there's sort of linguistic things that we can do that begin to take down some of the stigma. But look, I mean, Keith brought it up earlier about the persistence of racism in this country and how it influences policymaking. The stigma, the destigmatization efforts are going to be 20, 30, 40, 50-year efforts. And so we can't expect them to help us. We should be doing them, but we can't expect them to make a difference in the immediate future.
No, I wanted, I think there are two things. First, so Shatterproof has a media campaign they're undertaking. The National Academy of Science, Engineering, and Medicine had a stigma long workshop on it. So more and more people are talking about it. Whenever members of Congress talk about the issue, they often bring up their own experience. I also want to say that it was remarkable this week that, President Biden mentioned people in recovery at the State of the Union. He talked about the 23 million people in recovery in this country, and that having someone, the President of the United States, talking about that affirms. I mean, I heard from many people. He did it during the campaign too. That matters. It's a long-term effort. We need to work on our language, but also having more and more people talk about their personal experience makes a difference.
I agree absolutely with what Regina just said. That was a really important moment for my friends in recovery to have a president of the United States say that, and think to remember that cancer used to be a lot more stigmatized before we were able to treat it. And more people survived, and hope and despair and fear was replaced. Despair and fear was replaced with hope. In some reasonable sense, things could get better. And I think recovery is extremely important to highlight over and over again, because when someone's actively addicted, it's very, very visible. And when they are in recovery, they kind of disappear into the woodwork. And so it's easy for the average person to think addiction is doom, it is despair, it is pain, nothing good ever comes of this. And you don't see the fact that, in fact, people working alongside you have had addictive problems. People you admire have had addiction problems. People you love have had addiction problems. Making that visible to America, I think, can destigmatize how people respond to addiction.
Thank you all. We are almost at time, so I have one last question I'd just like to add to this conversation about stigma. I think it also connects back to what we were talking about earlier about the criminal justice system and criminalization of people who use drugs, and how that is so closely tied into the continuing stigma as well. Okay, so as a wrap-up question, reflecting on today's discussion, what's the most important thing we need to either do more of, do differently, or think differently about to effectively address the overdose crisis? And I would love for all of you to chime in on that.
Well, I just led a 25,000 word report on this, which I will now summarize in the next 5 hours for you. You can go to opioids.stanford.edu. You can read what me and 16 other people put together over 2 years, a comprehensive plan, but just very, very quickly, at least some of the highlights are: get the criminal justice system to stop punishing and start engaging in rehabilitation. Have the healthcare system take on substance use disorder permanently as an enduring condition of life, like heart disease, like cancer, so that every single healthcare system is competent to treat it and provide it. And last, don't forget, we got here in part through really bad regulation and gross profit seeking, and we need to fix those holes in the regulatory framework so we're not here 20 years from now with a different drug crisis that starts out of the pharmaceutical industry. Those are the big three.
So I'll tell you what I'm doing, which is I was really fortunate to have the support of Georgetown to start a Master's of Science in Addiction Policy and Practice. So what I'm trying to do is marry science, research with policy. We have a class of 10 people right now. It's a year-long program. Every year I'm going to have 10 more people, 15 more people, 20 more people come through this program so that we can have addiction policy that's based on science and evidence and compassion. That's what I'm doing.
Yeah, I'm not a big fan of one thing. So the first two things that were just shared, I think are certainly reasonable and important. I want to say in my 30 years, we've created incredible biomedical preventions and treatments for the things that sort of afflict people who inject drugs. So we have effective treatment for HIV, we have cures for hepatitis C, with naloxone, we have growing number of medications for opioid disorder. We'll probably have some for methamphetamine in the next decade or so. But to make all of those things work, we need to have an infrastructure that reaches these populations. And so we have to invest in communities, community-based organizations, people with lived experience, so that they have the jobs that can see that these effective treatments and cares reach the people who need them.
Thank you all so much.
Thanks, everybody.
I'll just join in thanking you guys all so much for joining us. It was such an important and rich conversation. And I appreciate all of you spending an hour with us this afternoon. And thank you, the audience, for joining us. Please save the date and join us for our next event, which is a conversation on addressing structural racism in Medicaid to promote health equity. And that's in April on the 15th. Until then, please stay safe and we'll see you then.